Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lectures, today we'll be discussing on one of the very interesting topic, that is gastroparesis. I feel that this will be very helpful to you in your everyday practice, as well as maybe ask in your theory as a short note or sometime even as a full question. Mainly very useful to fourth year students and also to the interns and the person who are doing private practice. The earlier lecture we have already discussed on dyspepsia. This is a very close differential diagnosis in dyspepsia because gastroparesis also gives rise to dyspepsia. And one of the very common disorder you see in your everyday practice, and one of the most common cause of gastroparesis is diabetes mellitus. So we'll be going through that particular portion. So gastroparesis, meaning very simple, gastro means stomach, paresis means weakness. So weakness of the stomach producing different symptoms and signs will be labeled as gastroparesis. We'll be discussing under some of these headings as routine, definition or introduction, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. Gastro means stomach, paresis means weakness. Usually it is not paralysis, but it is a weakness of the muscle wall producing group of symptoms and signs will be labeled as gastroparesis. So gastrointestinal disorders which involves delayed gastric emptying in absence of mechanical obstruction. This becomes a very important part, that there should not be any mechanical obstruction. So gastroparesis is always diagnosed only after a good investigations like upper GI endoscopy or by barium meal or by doing a dynamic study of stomach. That is what we call as a gastric emptying time. Gastric motility and emptying is a complex process. This complex coordination involving sympathetic and parasympathetic system, that is vagus nerve. Parasympathetic system is the vagus nerve. And there are cells which are present in the stomach called interstitial cell of Casal, which acts as a pacemaker cell in the stomach to produce a proper contraction of the gastric musculature. And any abnormality in this particular pacemaker cell stimulation leads to a condition we call as a gastric paresis or gastroparesis. Female to male ratio almost 3 to 4 is to 1. So it is 3 times to 4 times more common in female as compared to males. So it is a disorder which is delayed gastric emptying in absence of mechanical obstruction. It is a term which is derived from Greek, that is gastro, that is stomach, and paresis means partial weakness or partial paralysis. So there is a delayed gastric emptying in absence of mechanical obstruction, and it is associated with one or more of the following symptoms like postprandial fullness, early satiety, nausea, vomiting, bloating. If you remember that these are all the symptoms which are also present in dyspepsia. But you have to prove that there is delayed gastric emptying. And if there is a delayed gastric emptying by investigations, we'll label that as gastroparesis. So definition is based on an objective measurements of gastric emptying. And its prevalence is almost close to 2%. So common symptoms: nausea, vomiting, postprandial fullness, abdominal pain, early satiety, belching, and weight loss. Weight loss is secondary due to all these other symptoms because of decreased intake of food. Etiology wise, the most common cause are: 1. Idiopathic. We are not able to identify the exact cause for gastroparesis. And second big cause is diabetes mellitus, and that is labeled as diabetic gastroparesis. It is more common in type 1 rather than type 2. And in diabetes mellitus, it is autonomic dysfunction which is responsible for gastroparesis. We also labeled as diabetic neuropathy, but as it involves the autonomic system, we label that as diabetic autonomic neuropathy. Very common. There are some drugs which can also end up with gastroparesis, like opiums, or we call opiates, tricyclic antidepressant, CCB, cyclosporine, phenothiazine, dopamine antagonist, octreotide, liraglutide, lithium. This is a very common drug utilized in psychiatric disorders. This tricyclic antidepressant is a common, again, progesterone, dopamine agonist, clonidine, etc. Out of which the opium tricyclic antidepressant comes quite high up in the list. Good number of time it is also seen in a person with a post-surgery, like gastric resection, vagal nerve, like vagotomy, or even in case of a partial gastrectomy, etc. It is also seen in the neurological disorders like Parkinsonism, multiple sclerosis, collagen disorders like scleroderma, amyloidosis, some conditions which involves the spinal cord, following a gastric infections like post-viral gastroparesis, particularly rotavirus and norovirus, etc. So you can see here, there is a big list: neurogenic causes, myogenic causes, and other etiology, out of which the topmost in the list are the two, that is diabetes, where type 1 is more common as compared to type 2, and idiopathic. Then comes medications, post-surgical, post-gastroenteritis, neurological disorders, and connective tissue disorders, which we have already mentioned before. So major factors are diabetic gastroparesis, idiopathic, and drug induced. These three comes topmost on the list. And then comes other like following a viral infection, neuromuscular disorders, chronic intestinal pseudo obstruction, collagen disorders, Parkinsonism, and post-surgical. Even if you see the list, idiopathic is almost 36%, diabetic is 29%. Together, it is almost 65%. While another 13% is post-surgical, and Parkinsonism is 7%, close to 7%, 7.5. Collagen vascular disorder 4.8. So these are the common groups. So idiopathic comes topmost on the list, second is diabetic, then comes post-surgical, and then Parkinsonism. Now we are more interested because we come across a diabetic person quite frequently who presents to you with a dyspepsia symptoms. So whether it is a gastroparesis. So gastroparesis and diabetic correlation. 83% of the patient with definitive gastroparesis had diabetic gastroparesis. So you can see the incidence of diabetic gastroparesis quite high. Diabetic gastroparesis includes delayed gastric emptying, upper GI symptoms, and diabetic dyspepsia. 40% of the patient with diabetes mellitus has asymptomatic delayed gastric emptying. So this becomes a very big group responsible for diabetic gastroparesis. It is more common phenomena in type 1 as compared to type 2, we have already told you, and it is almost 4 to 4.4 times fold higher than type 2 diabetes mellitus. And also the cumulative incidence of delayed gastric emptying in a patient in type 1 diabetes mellitus is 5-fold higher as compared to type 2. Diabetic gastroparesis is associated with more severe manifestation in type 2 diabetes mellitus. Delayed gastric emptying in a patient with a diabetic gastroparesis occurs along with diabetes microvascular complications like neuropathy, retinopathy and neuropathy. These are more common in type 2. Symptoms in diabetic gastroparesis are severe with type 2 diabetes mellitus with type 1 as compared to type 1. So, symptoms are more common with type 2 diabetes gastroparesis like abdominal pain, early satiety, postprandial fullness, bloating sensation, heartburns, dysphagia, nausea, vomiting, etc. These symptoms resolves, so resolution of symptoms noted in majority of patients within 3 months of onset. So severe symptoms are related to poor glycemic control and poor nutritional status, because diabetic gastroparesis will lead to poor nutritional status and there is an increased risk of hypoglycemia. So there is a what we call as a vicious cycle. Delayed gastric emptying, there will be upper GI symptoms. So because of delayed gastric emptying, delayed absorption of nutrients, inconsistency with a dose of oral hypoglycemic agent or dosing time of insulin. So chance of hypoglycemia will increase, correction of hypoglycemia, and during that correction of hypoglycemia there is always a chance of overcorrection of hypoglycemia, and that will lead to hyperglycemia, and that hyperglycemia will further worsen delayed gastric emptying, and this will be a vicious cycle. So indirectly a good control of diabetes mellitus will help to break this cycle. In last lecture we already mentioned the relation between what we call as gastroparesis with dyspepsia, which we divide into two groups, organic groups and idiopathic groups. Now idiopathic groups is also called as FD. Now this particular group has got little overlapping with gastroparesis. Etiology wise we see Helicobacterium pylori is very commonly for factitious dyspepsia. Genetic predisposition, psychological factor and duodenal inflammation. While diabetes, post-surgical, connective tissue disorders, infiltrative disorders, etc. is more common for gastroparesis. But medications, post-infection and idiopathic is a common etiology for both. Same way if you go to the pathophysiology, there are some common pathophysiology for both, like delayed gastric emptying, impaired gastric accommodation, abnormal duodenal feedbacks, visceral hypersensitivity is common in both. Indirectly, there is a little overlapping of both pathophysiology as well as etiology. So dyspepsia, we have already discussed this slide, that delayed gastric emptying can be due to visceral hypersensitivity to acid, lipids and distension of stomach. There is a neurohormonal dysfunction, even H. pylori play a little role, acute GI infections, autonomic dysregulation and also psychosocial and stress. So delayed gastric emptying also can lead to dyspepsia, which can be idiopathic, and genetic susceptibility is more common in dyspepsia rather than in case of gastroparesis. It is more common in that group. But delayed gastric emptying will be both for FD or for gastroparesis. We have already mentioned that because of gastroparesis, you can end up with all these symptoms and signs. That is nausea, vomiting, postprandial fullness, abdominal pain, early satiety, belching sensation, weight loss. These are also seen in dyspepsia, because dyspepsia is a broad terminology. So what is more common in gastroparesis? In gastroparesis, there are few pathophysiology which is playing a role. One, this fundus part, that is hypomotility. There is a hypomotility in fundus part. Second, there is also hypomotility in an antral part. So it is called antral hypomotility and fundal hypomotility. There will be antero-pyloro-duodenal segment going into spasm. So this portion goes into spasm. And fourth, gastric pacemaker, which is a cell of Casal. There will be dysrhythmia in that particular, which will produce dysmotility in gastric part of the stomach. And there will be excessive inhibitory feedback mechanism. All these play a role in producing gastroparesis. So if you look here, there are a lot of different types of factors which are playing a role. There is a sensory neuropathy which will produce pain. There is a delayed gastric emptying that will produce nausea, vomiting. There is a gastric dysrhythmia due to abnormal pacemaker activity that will produce nausea. There is a decrease NOS neurons, that is nitric oxide sensitive neurons. So there is a defective accommodation and that produces early satiety. There is a defective antral mixing and that is secondary due to abnormal pacemaker activity and impaired electromechanical activity, etc. So these are the multifactorial. So there are a lot of factors: gastric emptying, gastric distension, small intestinal nutrients and chemosensitivity, proximal gastric accommodation is affected, esophageal dysmotility, small intestinal dysmotility, gastric electrical rhythm is disturbed, vagal afferent stimulation is being affected, and there is also a central process which is being affected. So there are a lot of factors which are there. Some possible mechanism for dysmotility is enteric nervous system dysfunction, extrinsic nervous system dysmechanism. This is affected by diabetes mellitus or by spinal cord injury, and smooth muscle dysfunction. These are all the three mechanisms which has been proven and explained, producing gastric neuromuscular dysfunction. What are the classical clinical features? Fullness after starting a meal, abdominal bloating sensation, abdominal pain, nausea, vomiting, and because of that, decreased appetite, weight loss, malnutrition. Person can also complain of heartburns. These are all the symptoms which are very, very common. And so weight loss, vomiting, nausea, reflux, bloating sensation, abdominal pain, decreased appetite, early satiety, and weight loss, which is cycle. So as this is a chronic process, so there is a chronic nausea, vomiting, can vomit undigested food, increased frequency and severity of vomiting in diabetic gastroparesis. It is more common with diabetic rather than idiopathic. While in idiopathic, early satiety, postprandial fullness, and upper abdominal pain which is in the form of burning sensation, crampy sensation, and worsen with eating, is more common with idiopathic. It is also present in diabeticals. Bloating sensation, belching sensation, weight loss, dyspepsia, we call functional dyspepsia. Peripheral neuropathy is quite common finding in diabetic mellitus, particularly type 1 more common as compared to type 2. But peripheral neuropathy will be more common with type 2 rather than type 1. So nausea, vomiting, very common, and particularly may vomit out undigested food particles. Feeling of early satiety, feels full quickly as well as feels full for a long period of time even after eating, because there is a delayed gastric emptying. Quite common heartburns, food sitting or staying in the stomach for a long period. Gastric acid content enters into the esophagus and persons will feel that heartburns even after a long period of meal. Upper abdominal or epigastric abdominal pain is very common. It is a weight pain, burning sensation, cramping sensation, and it is worsened with eating. Good number of times they complain that indigestion rather than pain. Bloating sensation, belching sensation, reduced appetite, weight loss is quite common. Weight loss is more common because of reduced appetite, chronic nausea, vomiting, and abdominal pain worsened by eating, so person eats less, and that's the reason why person will have a weight loss. And food sitting, or we call staying in a stomach for a long period because of delayed gastric emptying, that's why they get good number of time bloating sensation, belching sensation. Severity of gastroparesis is decided by doing a study, what is called gastric emptying time. If 10 to 15% of the food retention at the end of 4 hours, then it is called mild. 16 to 35% is called moderate. More than 35% is labeled as severe. And invariably this severe person will require nutritional supplements and will require non-pharmacological treatment, more common as compared to mild and moderate. There are a lot of conditions which mimics gastroparesis. So they are called gastroparesis mimics, or we label that as differential diagnosis. Either they are identical like gastroparesis, like cyclical vomiting syndrome, cannabinoids hyperemesis, eosinophilic gastroenteritis, gastric outlet obstruction, functional dyspepsia, rumination syndrome, bulimia, psychogenic vomiting, etc. All those are also mentioned here. And all this can be easily differentiated just by doing gastric emptying time. So there is an overlapping of functional dyspepsia with idiopathic gastroparesis. In idiopathic gastroparesis, postprandial, nausea, vomiting, fullness, bloating sensation, pain with severely delayed gastric emptying. While in functional dyspepsia, epigastric pain with normal gastric emptying is a typical features of functional dyspepsia. So the main difference between idiopathic and functional dyspepsia is only after gastric emptying study, and there will be overlapping in this group. You will have some features of functional dyspepsia, you will have some features of gastroparesis. So these are overlapping areas. So dominant symptoms like postprandial fullness, early satiety, epigastric pain, epigastric burning, say uninvestigated case, and another person is having pure nausea, vomiting only. So in this particular two groups, this is postprandial fullness, while here it is mainly nausea, vomiting, and there is negative endoscopy. So you got one group which is more fitting with functional dyspepsia and one group chronic nausea vomiting. Now in both this, you go for gastric emptying time. If it is normal, it will fit more with functional dyspepsia and normal gastric emptying. That is means these symptoms with normal gastric emptying classically in favor of what we call as a functional dyspepsia. And if there is a delayed gastric emptying, it is a functional dyspepsia with delayed gastric emptying, means maybe overlap. While in chronic nausea vomiting disorders, if there is normal gastric emptying, it is a chronic nausea vomiting disorders with normal gastric emptying. But if there is a delayed gastric emptying, it is classical gastroparesis. So, for diagnosis of gastroparesis, first step is to rule out the obstruction either by CT scan or by barium study or by upper GI endoscopy. And second, to differentiate gastroparesis from other group, it is called emptying study or gastric emptying study, also labeled as scintigraphy, which is done either by radiotracer ingestion of eggs, and if it is positive, 60% of stomach contents in 2 hours is emptied out. If there is a retention after 4 hours, 10 to 15%, then mild, 15 to 35% moderate, and more than 35% it is labeled as severe. So this is a classical study which is called gastric emptying time, and after 4 hours, if there is a retention more than 10%, then it is going in favor of gastroparesis, and it is divided into mild, moderate and severe. And this is a type of an instrument which is being utilized, and this is what is called as endoscopy study. But best answer is by gastric emptying time. So symptoms consistent with gastroparesis, you ruled out the absence of mechanical obstruction either by endoscopy or by CT scan or by barium meal, etc. And then you got an evidence of delayed gastric emptying, which is also called as a gastric emptying scan or scintigraphy, and which is done by radiotracer ingestion of an egg which is containing a radioactive material, and that you try to identify how much is the gastric content has been emptied out, and that gives you the answer for gastroparesis. So scintigraphy is one. Second mode of investigation is wireless motility capsule. So person has to swallow that capsule and then you do the study. There is another study called as a C13 breath test. These are the 3 common studies which are being for gastric emptying time. There is one more study apart from gastric emptying is enteroduodenal manometry, which gives an idea regarding a dysmotility and pressure studies at antrums and at the gastroduodenal junction. There is one more study called as a functional lumen imaging probe. Short form it is called as a FLIP. This is also one of variety of study where it is not a gastric emptying, but you are trying to do the study of the function of the lumen by imaging probe, and that is called FLIP study. So these are all the different types of study which are being done. Electrogastrography, accommodation study like barostat or satiety testing, imaging study like SPECT imaging or gastric MRI, autonomic testing, deep tissue biopsy, etc. are being done, but nothing can replace this scintigraphy. Second common is wireless motility capsule, and third is C13 breath test. Now this is coming up. So in general, diagnosis is suspected based on a symptoms and signs in the setting of diabetes mellitus. If person is having some symptoms and signs, you are suspecting gastroparesis. So first what you have to do is exclude mechanical obstruction by doing an endoscopy or by barium study, and then go for gastric emptying time like scintigraphy, then breath test, that is C13, we already mentioned C13 breath test, or wireless motility capsule study. Diagnosis established. Now what you do? Lifestyle modification like optimize the diet, smoking cessation, limit alcohol consumption, etc. And stabilize the diabetes control. After optimizing the glycemic control, now you can decide for, if still symptoms are persistent, you can go for prokinetic followed by proton pump inhibitors. If person doesn't get good response, then you can go for botulism toxin, pyloric stenting, gastric electrical stimulation, and then last resort is surgical management. So this is the best slide which can explain you in short what you can do in a gastroparesis. So for all this purpose, we require a lot of people like clinical psychologists, biomedical engineers, radionucleotide studies, so radiologist, gastrointestinal nurse, dietitian, then surgeons, pharmacists, and gastroenterologists. So it is a big dilemma. So gastroparesis will cause nausea, vomiting, early satiety, all the symptoms and signs, weight loss, and when you examine the abdomen, you will get a succussion splash. On physical examination, even after 1 hour, 2 hour, 3 hour, 4 hour of meal, what you should do immediately, stop the drugs which decreases the gastric motility, so which slows down the gastric emptying, particularly opioids, clonidine, extended, which is what we call as a GLP-1 receptor agonist. Now you have to rule out mechanical obstruction by upper GI endoscopy, or by barium meal, or by doing radiological study for pylorus like CT or MRI. Then you can go for scintigraphy, and find out delayed gastric emptying. Now what you go for? Advise small meals, frequent meals, low in fat, and non-digestible fiber. If dietary supplements does not suffice, means lifestyle modification does not improve the symptoms and signs, now you can go for pharmacological therapy like prokinetic drugs. The first drug of choice is metoclopramide, and if not tolerated, does not give response, you can use erythromycin. So lifestyle modification, and then followed by medical therapy, or we call pharmacotherapy, antiemetics. In prokinetic drugs, metoclopramide is the first drug of choice, second drug of choice is erythromycin, third drug domperidone. These are set after that line. Then comes accommodation agents like buspirone. Then you can use neuromodulators like tricyclic antidepressants, SSRI, etc. There are alternative methods also, which are ginger, acupuncture, acupressure, magnetic therapy, etc. Now, if all this treatment does not give you any improvement, now you go for endoscopic treatment, which is called G-tube feeding, J-tube feeding. You can go for botulism toxins, injections, transpyloric stent, and then comes pyloromyotomy. And last is surgical intervention. You can have gastric stimulation, pyloromyotomy by surgical procedures, and then comes gastrectomy. So we divide into two big groups. One group which has got epigastric pain, and another group which has got a postprandial pain. or postprandial distension. Now this will be more common in a functional dyspepsia rather than gastroparesis. Indirectly, if uninvestigated, this is first thing which is being done. So in case of an epigastric pain, anti-depression drugs with treatment of H. pylori confirmation, and then treatment is given, and empiric proton pump inhibitor is given, along with lifestyle modification, and then you have a regular follow. In postprandial distress, first lifestyle modification followed by antiemetics, prokinetic drugs, and then antidepressants. These are the way it is being followed in functional dyspepsia. While in case of a gastroparesis, lifestyle modification, particularly diet, low fiber diet, small volumes, avoid fatty foods, spicy foods, insoluble fibers, liquid foods, avoid alcohol, smoking, and carbonated beverages, maintain good hydration, maintain good blood glucose control, avoid medications with delayed gastric emptying, particularly opioids, very common. Clonidine is another very common. Regular exercise, these are good number of things which will be included in conservative method. Does not give response, you can add pharmacokinetics, that is prokinetic agents like metachlorpropamide, or you can use domperidone, and trials should be there for minimum 12 weeks. Try not to use more than 12 weeks. Ideally we say that give it for a good adequate period. If does not give response, you can give erythromycin, and erythromycin should not be given for more than 4 weeks because tachyphylaxis will be there. So these are the treatment which has been tried in gastroparesis. Diet, you can follow this diet. Fat will be 15 to 20 grams, calcium will be 600, sodium will be 1200, carbohydrate 260, protein will be 40, and iron will be 70. And this is small meals, 9 a.m., 11, 1 p.m., 4 p.m., 8 p.m. At regular intervals, small meals, low fat, low fiber, avoid fatty meals, and spicy foods. So small meals, low fat diet, limit roughages and high fiber food. Consider homogeneous foods, vitamin supplements should be there. And as far as drug, prokinetic followed by antiemetics, and then you can go for other drugs, particularly like erythromycin. If person is having refractory symptoms now, you can go for IV fluids, IV medications, and nutritional supplements. For long-term management, you will have to do now intervention like jejunal feedings, laparoscopy, pyloroplasty. There is one called as a gastric per-oral endoscopy myotomy. So this is gastric per-oral endoscopic myotomy. So these are some of the procedures which are being done. So these are the drugs which will be utilized, followed by gastric stimulation, and then followed by what we call as intrapyloric botulism toxin injections, transpyloric stent placement, and then last gastric per-oral myotomy. So gastric duodenal manometry will help you to identify endoflips. No gastroduodenal manometry or endoflips, then you can go for pyloric botox injections. If there is a good response, you can go for pyloric interventions like laparoscopy, pyloroplasty, or GPOM. If there is a poor response, you can go for medical treatment jejunal feeding, bag drainage, total parental nutrition, etc. So these are the flow charts which you can follow in a refractory gastroparesis. This is what is called transpyloric stent placement. This is the endoscope and you place the stent at the pylorus. This is gastric electrical stimulation which has been there. This instrument will remain outside and this will be the electrode which will be placed over the gastric or stomach wall, and that will give a stimulation to the gastric wall, producing proper motility. There are some non-invasive which are under trial, like this is stimulation of vagus nerve. This is another method. These are different technology which are being utilized but yet not been approved. So there is an overlapping between this functional dyspepsia and gastroparesis. If person has got an overlapping, both treatment should be done. That is diet, lifestyle, proton pump inhibitor. For nausea, vomiting, antiemetic drugs. For gastric emptying delay, prokinetic drugs. For abdominal pain, antidepressant can be utilized. And for gastroparesis, GJ tube, gastric electrical stimulation, GPOM, and final is surgery. So this will be the difference between gastroparesis and dumping syndrome. Dumping syndrome is very common following some surgical procedures, quite common. Symptoms remains nearly very close to each other, but in gastroparesis you have to give small, low fat, low fiber meal, while in dumping syndrome small, high fiber, high protein meal. You require lot of dietary supplements, while in gastroparesis, being a diabetes most common, you require a glucose control. In gastroparesis, prokinetic erythromycin will give a good results, while in case of a dumping syndrome, acarbose, somatostatin analogs like octreotide, etc. will be more helpful. In gastroparesis, other treatment like Botox, Esoflips, then gastroesophageal feeding, GPOM, surgical pyloroplasty will be helpful. While in case of a dumping syndrome, gastric bypass reversal, pouch restriction, pancreatic resection, etc. will be more helpful. Complications of gastroparesis: dehydration, malnutrition, nausea, vomiting, blood sugar level will fluctuate, and acute daily symptoms will be present as a part of gastroparesis. In end, delayed gastric emptying due to diabetic gastroparesis is associated with increased rate of hospitalization and mortality. Domperidone can be a choice of prokinetic drugs in diabetic gastroparesis, and it is comparable with metoclopramide. Management of dyspepsia will require proton pump inhibitor. Omeprazole shows a better response in GI symptom relief in over all other proton pump inhibitor. Omeprazole additionally, when used along with anti-diabetic therapy, improves glycemic control in diabetic patient. Combining omeprazole with domperidone provides superior heartburn relief as compared to omeprazole alone. So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable and I appreciate that you have spent some of the time with me. So thank you once again. If you like this particular lecture, don't forget to press button like, subscribe, and you can share with your friends. And also you can give your good suggestions so that I can improve in my lecture. See you in next lecture. I feel this will be very helpful to you in everyday practice because you will see lot number of cases of dyspepsia, and one of the condition which fits in a dyspepsia is gastroparesis, because there is lot of overlap between gastroparesis and functional dyspepsia. Organic dyspepsia is very easy because on investigation you confirm the diagnosis, while good number of time in a gastroparesis and functional dyspepsia the investigations are negative. So only by doing gastric emptying study you will be able to identify gastroparesis, and that will be one of the most important clue.